3 p.m. Time for our health and wellness feature.
702
Health and Wellness.
So on our health and wellness feature this morning, we are discussing how to treat psoriasis. It's a skin problem affecting, I think, about 2% of the population. A chronic disease in which the immune system becomes overactive, causing skin cells to multiply too quickly. So you've got these patches of skin becoming scaly and inflamed, and most often on the scalp, on the elbows, on the knees as well, but other parts of the body can be affected as well. So we're looking at this morning, and if you this is something that you suffer from, something you've experienced, you know someone who has, you've got some questions on how to treat it, or you're going to tell us how you've treated it successfully, you can give us a call on 011-883-0702. WhatsApp's on 072-702-1702. Dr. Irshad Essack is a dermatologist who's guiding us through this conversation. Dr. Essack, thank you so much for making time. Good morning.
Good morning, Clement. How are you? And good morning to your listeners as well.
Yeah. So what happens in the immune system for one to develop this condition?
So psoriasis, as you rightly pointed out in your introduction, is a disorder of the immune system that is largely controlled by and influenced by the white blood cells in the bloodstream, and in particular a type of white blood cell called the lymphocytes. And these particular cells secrete, or they give off far higher amounts of certain pro-inflammatory chemicals. So these chemicals basically cause the skin to become inflamed. And as part of that inflammatory process, you have the cell turnover of the outer layer of the skin becoming accelerated. So usually your outer layer of the skin, those cells, they start very immature at a deep level, and as the days go by, they make their way to the outside of the skin. That process can take anywhere between about 75 to about 90 days. However, in psoriasis, those cells can cycle through that entire process in somewhere between about 15 to about 45 days, which then means the cells that present themselves on the outside layer are not as mature in order for them to provide a good skin function. And what you described earlier on as being those scaly areas are actually immature epidermal cells that fall off as a dusty flake, and in some instances it can be as thick like an armor plate scale that can come off the skin. And the redness and the salmon pinky color that you're seeing in the background is largely from the dermal vessels. So the second layer of the skin have to support this accelerated turnover, cell turnover. And what you're seeing, the pinkiness in the background, is actually the increased blood supply from the dermal vessels that are supporting this increased cell turnover.
And when exactly does it develop in life?
So there are I'm speaking strictly in the classic psoriasis vulgaris, or the common type of psoriasis. You have generally 2 age peaks. So somewhere around the age of 15, and then somewhere around the age of 50 is when you are going to have the most incidences of new cases of psoriasis. However, there are patients who are diagnosed before the age of 15, and some patients who are diagnosed way after the age of 50. Those who are diagnosed earlier on in their teens, there tends to be an association with a streptococcal sore throat. And we think that that's one of those type of infections that can trigger off that overactive immune system activity that results eventually in the psoriasis presenting itself on the body. In the older age group, there seems to be some sort of association with arthritis. And psoriasis tends to affect the musculoskeletal system as the only other system that it affects. And for those patients who have a later on presentation, they tend to have a greater association with psoriatic arthritis. Now, psoriatic arthritis, which affects the joint, can easily mimic something like rheumatoid arthritis most commonly, or even osteoarthritis. So you may find patients, for example, in their 30s and 40s complaining of joint pain to the GP, not quite figuring out what the problem is. Sometimes are being labeled as being rheumatoid arthritis, only to find that the skin rash starts a little bit later, and then only is the connection made between the psoriatic arthritis and the skin psoriasis itself. But there can be a long time span between the presentation of the skin rash and the joint involvement, sometimes as much or as longer than an entire decade between the two symptoms actually presenting in the same patient. So you've always got to be wary of there being some sort of underlying connection between the two. But you can get patients in the early teens that can present, and get those who present later on in life as well.
Yeah. And how does it, in terms of like long lasting, does it come and go? How does it work?
So technically speaking, psoriasis is not curable, because psoriasis basically is associated with a gene mutation on the SORS1 gene, and that's on chromosome number 1. Now, once you have that genetic problem, it's difficult to undo that. So, technically speaking, psoriasis is a chronic problem. However, in terms of its activity, its severity, and its evolution and course of action, psoriasis waxes and wanes through the lifetime. So you go through periods where most patients will have disease-free periods, just a little bit of hyperpigmentation or a brownish spot with no scaling, no itching, no irritation, but they've still got psoriasis. And you get flares that may occur intermittently. So every now and then a new patch may develop, pink along the way, usually with a scale over the top, may become itchy, may mimic something like eczema. But that's the general course, like you pointed out, in most of the 2% of the population that suffer from psoriasis. But in some individuals, the psoriasis can run a very stormy course, and it's more active than inactive. And they are the ones who tend to have large body surface area involvement. So more than 50, 60, sometimes more than 90% body surface area involvement in psoriasis, which can include the scalp, the entire trunk, the arms, the legs, the genitalia as well can also be involved. So psoriasis can vary in its presentations, and some patients may have a small 5 Rand coin sized patch that may occur on their back. No one even bothers about it. It's a bit itchy, and they go on with life without even applying an ointment or a cream. And you get those may require hospitalization because there are some subtypes of psoriasis that may result in pustules that develop. So lakes of pus that get trapped underneath the first layer of the skin. And those are those white blood cells that I'm talking about that tend to work their way into the skin and cause these little water bubbles in the very beginning. And then thereafter, as the white blood cells get into those water bubbles, they develop pustular lesions. So the quality of life of a psoriasis sufferer can vary from being totally unaware of the disease all the way to completely debilitating if they've got associated arthritis. They've got social, occupational, and functional social and occupational dysfunction. They are unable to hold on to jobs, unable to stay in relationships, become stressed, financially stressed, medical bills, unable to be at work. So the implications of psoriasis can be far-reaching than just having a rash.
Okay, I want to take some calls now, Dr. Essack, just to hear from our listeners if they've got some questions. Maybe they've got some ways they want to share with us on how they've managed to treat it over the years. 011-883-0702. You can send us a WhatsApp as well on 0727021702.
702. Health and wellness.
Nico, you are calling us from Midrand. Good morning.
Good morning, Clement. How are you?
I'm all right, man. Go ahead.
Thank you, Clement, for bringing up a topic like this one. Because I think for some of us, I mean, like the doc has indicated that it affects only 2% of the population. I'm one of those ones living with psoriasis. Unfortunately, in 2018, actually, I was diagnosed with autoimmune disease. And psoriasis is one of the autoimmune diseases. And unfortunately, what happens is with autoimmune disease, there are so many things that might attack you. So I had several issues with health issues, and I didn't know what was the cause of this until I was diagnosed with autoimmune disease. So with me, I developed those lesions that he's talking about on the body, and it starts very itchy. And at some point, it might get very itchy to such an extent. I felt like I can just get into the fridge and stay in there, lie on the floor until I was hospitalized. And then from there, I started going through, I was given medication. And then from there, I went to a dermatologist who then prescribed for me to use at least, for bathing, I only use glycerin soap. And that's it, nothing else. And then to apply on my body, it's only E45. And since that time up until now, I've never had any episodes of skin problems, and of which, even if there is something, E45, if you apply it, even if it's itchy somewhere else, it acts as a, let me say, something to cure that particular itchiness or whatever. So since that time, I've been using E45, and it's been working well for me. Unfortunately, socially, you're no longer going to use perfumes and all those kind of things that's so that you can smell nice or something like that. But for me, I think it has worked up until now. I've never had any issues.
Sure. Yeah, no, thank you so much for the call, Nico, and for sharing with us how you've managed to deal with it. I'll get Dr. Essack to also respond to that. Let's go to Tuli, who's calling us from Benoni. Tuli, good morning. Hi, Tuli.
Hello?
Hi, go ahead.
Oh, yes. I believe I have psoriasis because since I was like 11 years, 12 years, I did come out some patches on my neck, and then I actually didn't go to the doctor. I heard from some people and via online, so I did buy some over-the-counter medicine, which is called Tire. So the medicine does remove them, but they do come back every year during summer. So, yeah.
Oh, okay. Yeah, Tuli, thank you. Let's hear what Dr. Essack says, and maybe he'll have some tips for you as well. Dr. Essack?
Okay, so Clement, from your first caller, there's just 2 points that I want to highlight. The first thing is that, as this caller pointed out, the disease can be severe enough to warrant hospitalization. So it's not something to be trivialized. And like I said, also from a social point of view, you kind of obstructed in not using perfumed and fragrant products, which certainly impacts on quality of life for most patients. So again, even though the majority of patients may have relatively mild disease, they are those who suffer from severe disease that require a lot of social and psychological support. And it is also been shown that patients with psoriasis are more likely to have depression and substance abuse as well, in order for them to cope with their particular problems. So it's not a disease to be trivialized along the way. The second point that the first caller made was regarding the glycerin and the E45. And just for the listeners out there, E45 basically is an over-the-counter type of emollient. It is like a moisturizer. So the reason why this particular patient may be using it after his disease has gone into, I'm not going to use the word remission, but what I actually mean is that the disease has now gone quiet. He's using the glycerin and the E45 to try to restore the skin's barrier function. Now, I mentioned earlier on that because of the increased cell turnover, the outer layer of the skin doesn't function properly. And one of the skin's function is to keep bacteria out and is to keep moisture in. So by using a glycerin soap or an emollient, what you're actually doing is you're trying to assist the skin in repairing its barrier so that it can function properly. That alleviates much of the itch. Mostly, you can get away with that type of strategy when your disease, like I said, has gone quiet. Coming to your second caller, she mentioned that she had some patches around the neck, and it tends to flare up from time to time. If you look at the classic psoriasis vulgaris, the most common type of psoriasis, because you get other subtypes and variants of psoriasis, but in the classic type of psoriasis, the common areas that are affected are usually the elbows and the knees, the umbilicus or the navel area, the lower part of the back, the upper part of the buttocks are very, very common places for psoriasis to occur in psoriasis vulgaris. In less commonly, you can get scalp involvement, so it may present just like a flaky dandruff. Someone thinks that they may be having a fungal infection of the scalp or an eczema of the scalp, but psoriasis can present in the scalp. Psoriasis can also affect, like I said earlier, the genital area. So in younger kids or children, it may appear like a nappy rash type of distribution in the genital area. And psoriasis can also affect the nails. So nail psoriasis is sometimes commonly mistaken for being a fungal infection of the nails. The fungal infection can superimpose psoriasis, or the psoriasis can be present itself without having a fungal infection. So brittle nails, little small dots or pits on the nails, separation of the nails from the nail bed, loose nails, may all be indicators of nail psoriasis. And there are some patients who have nail psoriasis exclusively without having psoriasis anywhere else. The same goes for genital psoriasis and the same goes for scalp psoriasis. So it can be very, very localized in some patients.
Yeah. Okay, let's go to some WhatsApp voice notes.
Hi, Clement. Can you please ask your guest what is the main difference between psoriasis and pityriasis? Because I was diagnosed with pityriasis, but then when you look it up, I was told that it was supposed to be a once-off flare. Mine happens multiple times. It's not itchy or flaky like psoriasis, but you basically get like patches on my skin because I'm dark in complexion, so they start off. It's difficult to describe, but they eventually do become dark, but they're never itchy. They flare up every now and then I use the creams, and now I was also told to use anti-dandruff shampoo, and that seems to actually be bringing it out even more rather than clearing it. So can you please find out what the difference is?
Okay, I will in a moment. Ayob, you're in Randburg. Good morning.
Clement, good morning, and good morning to Dr. Essack. So I've been undiagnosed, living with psoriasis for just over 20 years. I think I was first diagnosed about 10 years ago, and that was as a result of it now spreading to my nails. Started off initially as little dots on the inside of my arm. It's progressed now to the point where I have patches in different parts of my body, as well as what presents as psoriatic arthritis. My GPs have had me treated topically for the last couple of years, but I am looking for something a lot more long-term, meaningful in terms of treatment for the psoriasis.
All right, some long-term treatment. All right. Dr. Essack, just quickly in a minute, please, if you can.
Okay, so your first, the third caller regarding psoriasis versus pityriasis. Pityriasis is not a diagnosis on its own. It's actually a group of disorders. So something that is pityriasis form refers to a small, fine, branny-like scale, like a cornflake type of a scale, whereas psoriasis gives you a thicker scale. So that's an entire different chapter in the textbook. But what she's describing is a condition called pityriasis versicolor. That's what it sounds like. And what she's been treated for is she's being treated for a yeast or a fungal infection, which seems to be the most common cause of pityriasis versicolor. Because you do get something else called pityriasis rosea. You also get pityriasis lichenoides. Okay. Those are all different, completely diagnoses. Regarding the second patient regarding longer-term treatments, yes, there are longer-term treatments available. We include in that category non-cortisone immune suppressant therapy, because you want to suppress an overactive immune system. There are various options out there in the market. And over the last 20, 25 years, even after 30 years, there's been a lot of foray in the pharmaceutical industry into the space of a group of drugs called the biologics. And the biologics tend to switch off some of those chemicals that drive psoriasis, specifically. They work very well. Unfortunately, they do come with side effects, which can be managed. However, the prohibitive factor at the moment is funding.
All right. Yeah. Dr. Irshad Essack, I really appreciate your time this morning.